Good morning, dear audience. I will talk about the recent progress of my research on the diagnostic and therapeutic options in sepsis-associated coagulopathy. My name is Tímea Mátyási-Dombi. I'm a second-year PhD student and an anesthesiologist currently working in Manninger Jenő Trauma Center, Budapest. My goal is to improve personalized hemostasis management for critically ill individuals. Therefore, I have two ongoing projects. The first one is a systematic review and meta-analysis, and the second one is an RCT protocol. First, I investigate the efficacy and safety profile of thrombomodulin in sepsis-associated coagulopathy. Sepsis can disrupt the balance of hemostasis in up to every second cases, forming microthrombi, leading to different organ dysfunctions and high mortality. Thrombomodulin, as an anticoagulant agent, can restore this balance. That's our hypothesis. Thrombomodulin, apart from anticoagulant effect, has also anti-inflammatory, endothelial protective, and antifibrinolytic effects, as you can see on this big picture. However, the guidelines are controversial. While the Japanese recommend the usage of thrombomodulin, the international guidelines do not. It is because of the mixed evidence and the limited supply, because currently it can be it's approved only in Japan, and the rest of the world use it for clinical investigations. So we use this PICO framework for our study, and with this search key we searched the 5 main databases and found 34 eligible articles after the selection process. Regarding our result, first I would like to talk about 28-day mortality. The overall effect was 0.66, which means the odds ratio of death was reduced almost 1/3. In the observational studies, it was a statistically significant effect. However, in the randomized control trials and the propensity score studies, the direction of the effect was the same, but it didn't reach statistical significance. However, observational studies can overestimate the effect according to bias, but randomized studies also have limitations because the heterogeneity of the population, the disease severity, the different coagulopathy definitions limit their result. In the intensive care unit mortality, we saw an even more remarkable effect because the odds ratio of death decreased to almost half. However, the quality of evidence was very low due to imprecision and moderate risk of bias. The next outcome is the severity of coagulopathy, where we used the Japanese DIC score range. There were difference in DIC score and resolution rate on day 7. After thrombomodulin therapy, DIC score was significantly lower, and it was mathematically significant and also clinically relevant because it led to the resolution of coagulopathy. However, after the resolution of coagulopathy, we couldn't see any difference between the SOFA scores after 7 days. But regarding ventilatory-free days within 28 days, we saw that mechanical ventilation was 1.5 days less in the thrombomodulin group, which is clinically really important because less ventilation leads to less complications. Thrombomodulin was also safe because there were no difference between the bleeding rate in the investigated studies. So our conclusion is that thrombomodulin shows therapeutic potential in sepsis-associated coagulopathy by facilitating the resolution of coagulopathy without increasing the risk of hemorrhage. However, its effect on mortality remains unclear due to inconsistent evidence. So we suggest to plan an RCT with more standardized coagulopathy definitions and homogeneous cohorts. Our study's strengths are that we evaluated RCTs and non-randomized studies separately as well, with over 8,000 patients. However, the limited number of RCTs, the Japanese studies, and the potential overlap in registries may limit our results. We have completed our manuscript, and the next targeted journal will be Critical Care Medicine. My second project is ThromboSac, an RCT protocol draft about the safety and efficacy of thrombomodulin in patients with sepsis-associated coagulopathy. As I mentioned, we need more standardized coagulopathy definitions, and in the recent years, there's a new scoring system, the SIG score range, which is more specific to the septic patients than the Japanese score. Also, if we see coagulopathy, it's a very heterogeneous population, and there is thrombotic and hemorrhagic phenotypes. If we want to examine these phenotypes, we not just need the SIG score, we need a viscoelastic test to differentiate these phenotypes. And it can more or less guarantee to give the right time the patient, to give the right, for the right patients this thrombomodulin therapy. And lastly, we would like to homogenize the disease severity. We can evaluate it with the SOFA score. We want to include patients who are more than 10 points on SOFA scoring system. And one minor comment for the East Asian versus Caucasian paradox, which will be also important, because the bleeding risk, there's a increased bleeding risk for the Asian people compared to the Caucasian patients, and in the dosage of the thrombomodulin, it can be very significant. So our clinical question for this RCT will be, does thrombomodulin resolve coagulopathy in patients with sepsis-associated coagulopathy, and so far more than 10. We plan to include patients over 18 years old with SIG scores more than 4, and we plan to make viscoelastic tests and identify the fibrinolysis shutdown in these patients. As I told earlier, according to the East Asian paradox, maybe for the Caucasian people, the standard dose isn't enough for the same effect, and that's why we plan to make a 3-arm study. And we would like to investigate resolution of coagulopathy with SIG score, viscoelastic parameters, and standard coagulation markers as well for primary outcome. And we plan to investigate other clinical and mortality outcomes as well. For summarizing, I would like, I really hope my first investigation, my first study will be published soon, and I plan to finish the second project this year. I have presented my results in the National Congress of Hungarian Society of Anesthesiology and Intensive Therapy this May. And I would like to end my presentation with the quotes of Csontváry Tivadar: "Every person needs a broader perspective to see more and to be aware of the divine nature. In a broader perspective, we find a new perspective. In a new perspective, we find a new life." Thank you for your kind attention.
Congratulations. I would like to ask that the Japanese studies are at the limitation. What is the reason?
There are some points, because here you can see just the RCTs are from the rest of the world, and all the other studies, the observational studies, and even one RCT is, two RCTs from Japan. So we have not enough data to conclude for the rest of the world. That's why we need more investigation. And also, as I told later, for example, we are not sure if this dosage is enough for the European and Caucasian people, because there are differences. There are studies where we see differences in the coagulation of these nations.
So congratulations for you as well for your presentation. I thought that it's best if I ask first, because I wanted to ask related to this slide.
Oh,
so it was a convenient part.
Okay.
Here we see odds ratio.
Yeah.
Do you know what is the difference between odds ratio and risk ratio?
The odds ratios from 0 to infinity, and the risk ratio is 0 to 1.
No. What is odds ratio then? Just
the odds ratio in this study, the odds of an event in the therapy and the control group compared to each other.
What about risk ratio?
It's the probability of an event in these two groups. It can be...
it's also a ratio,
yeah,
and it's not included in your
yeah,
topic.
it's not. We didn't use risk ratio
yeah. So
in our...
It's also a ratio, and you are right that you calculate probability, not odds, in both group, and you got just a ratio.
Mm-hmm.
But you knew well the definition of odds ratio.
Mm-hmm.
So thank you. It's just a remark after it that here we see RCT results, propensity score match results, and non-randomized things. I think that it's possible that their adjusted odds ratios are used. Am I right? So which type of odds ratios were present in the studies? These are raw odds ratios or adjusted?
Actually, it was raw odds ratios, not the adjusted. Not just in the propensity score matched, it was adjusted, but in the others they weren't. Okay,
so then what I think is that maybe it's better to separate. So what is in my mind that I'm not surprised that here the odds ratio is lower in the so the pool of the raw odds ratios. Because it's possible that, for example, more serious patients receive one of the treatment, or I don't know. So there can be some confounding behind it. So what I would do is I would separately pool the RCT and the propensity score match result, because they try to battle against confounding, basically. So RCTs without confounding due to the randomization, and propensity score matching try to basically counter-effect the possible confoundings. That's why I suggest you to separately pool as well the RCT with the propensity score matching, because these are the adjusted ones basically.
Okay, so you mean you just want two subgroups?
Two plots, yeah.
Yeah,
So
okay.
here we don't see the pool of the first two subgroups together.
Yeah.
So I would put them in different plots basically. The first two, because they are adjusted, and there will be a separate plot for the row-odds ratio pools. It would be, I think, a bit better. And I just mentioned that, but I also mentioned that here that in RCT we don't have a significance result. It's just again matter of number of the studies basically. So, and even I think that if you just put one of them from the propensity score matching, it would become significant already. So, yeah, this is my comment, that try to separate. And here I think that you have enough evidence. So if we see the joint pool of the RCT and the propensity score matching, then I think it would be enough evidence.
Okay, we take it to consideration. Yeah.
You see
Thanks.
here as well, the overall is less, but the overall is not good here, I think, due to the difference between raw and adjusted versions.
Okay.
And I think it will be enough evidence. It's my point of view.
Thank you very much.
I have a short question. You mentioned that thrombomodulin was graded to C or D. Could you a little bit comment on this grading system? And do you know where thrombomodulin is in the range within all these coagulation factors, products of industry and so on?
You mean other anticoagulants? Actually, currently in septic coagulopathy, neither of other anticoagulants is not recommended more than thrombomodulin. So, because there is not enough evidence.
But in general, the grading 2C, is this excellent, good?
No, it's a weak suggestion. Yeah, I know, because as I told, the Japanese use it every day and in different scenarios, but it's just one country and not all of the world, and we need more studies to receive more evidence.
Timmy, do you think it's worth it to make your second study into a multi-center study? Ask our Japanese colleagues, some of which are actually co-authors in the paper, to have at least two centers, one in Europe and one in Japan. Yeah. Do you think it's worth a try? And second, what kind of differences would you expect to see between the data coming from the Japanese center and the European center?
I think we should definitely try, as it's a really exciting hypothesis, and there are some data in the recent years, although the data are mainly for the thrombotic events and bleeding risk compared in antithrombotic therapy. But still, I think, as we see in general, if thrombomodulin is good for the Japanese and they even have a higher bleeding risk, I think why isn't it good? I think the answer is that it's good, just not for everyone, every Caucasian. We really have to select the patients, and it's a good way to, but if we select the patients, we will have a narrow aspect, and we will receive data in a really, really, really long time. That's why it would be also good to have more centers involved in this investigation. So definitely my answer is yes.
Now I checked better the plots, and now I think that you don't have enough evidence is true, but definitely separate the two, I think. And again, I emphasize that you knew the answer for odds ratio, and only odds ratio is present in your study. So thank you again. I consider that you answered right my statistical question.
Okay, thank you.
So maybe a short question. So congratulations again to this nice presentation. So based on your knowledge and understanding, so what do you think about the optimal starting point of this thrombomodulin therapy?
Yeah, the RCT is used, and mostly the observational studies had a 24-hour time frame until the diagnosis and after the patient was eligible for the study, they had 24 hours to give the treatment for the patients. I think maybe I know that in clinical situations we need to use this 24-hour time frame, but the patients change even more rapidly. So it's also a problem that 24 hours is a really long interval for the therapy initiation, I think.
Based on this answer, so you should start immediately at the patient's admission, or?
We have to see the 6 score, do a viscoelastic test. Actually, it's not a long time gap. After that, we can give thrombomodulin. Yeah.
Thank you.